So let's look at pain and movement and how pain can affect movement patterns. There's multiple studies. I'm just going to go over a couple of them here. First is the fear avoidance model, confrontation versus avoidance. I think that whenever people get in pain, specifically low back pain, we certainly can put extreme fear in our patients without even realizing it. When we start dealing with a patient with low back pain, we can easily begin to give the instructions of, okay, I want you to keep your shoulders and your pelvis square. I want you to, not move your shoulders away from your pelvis. I want you to have a neutral spine all the time. And so we can almost, with our cueing, take our patients into a fear avoidance model of pain, meaning they become so afraid to move their spine that they become fearful to do anything that takes them out of a neutral spine. And we feed that. We feed that with our cueing. The spine is meant to move. It's made up of 24 movable parts. If there's one thing the spine is meant to do, it's meant to move. And so we need to be very careful that we don't take our patients into a fear avoidance model of pain because of our cueing. People go into pain and they have this painful experience. If they don't have any fear, they confront their fear and they move on. It's done. When people are fearful of their pain because either they don't understand it or they've been told to maintain a certain position at all times or horrible things are going to happen, they begin to fear that pain. They avoid different activities and they become disabled. They begin to have disuse atrophy and they become depressed because they're not able to live the life they're hoping to live. And then that feeds the pain experience, which then further feeds the fear of pain, the avoidance of activity, furthers the depression, and it just gets them in this cycle of fear avoidance versus confrontation of their pain. We need to be empowering people who are in pain. We need to make them understand what's going on, what their realistic fears should be, and I emphasize the word realistic, and really what the body is made to do, and that it is an incredible healer, and that this is going to be a guidance. Maybe we don't want them doing a lot of twisting and bending at first, but this is something that they're eventually going to be able to get back to. We just need things to heal eventually and have protected range of motions versus immobilized ranges of motions or immobilized joints. So I think our words and our cueing have a huge power and a huge impact on our patients and how they look at movement and if they confront it head on or if they become fearful and avoid the movement and therefore it feeds the pain experience. Catastrophizing is another thing we need to be extremely careful of with our patients. Patients can dwell on extremely negative consequences, and these consequences don't even have to be rational. When people don't understand what's going on, they can begin to go down a path of absolute uncertainty and complete catastrophizing. And then again, that makes them fearful. It makes them avoid activity and it makes them have further disuse of the body part or the area and become further depressed, further feeding the pain avoidance model. So we need to be very careful about catastrophizing. Again, we need to give our patients realistic expectations for what is going to happen in the rehabilitation process, as well as realistic information about what disease process that they're dealing with and what they're going through and what the potential outcomes are. So having extremely realistic expectations and relaying those to the patient is extremely important when dealing with people in pain. Other things to consider. We spend so much time working on stabilization of things that sometimes we need to destabilize. So we need to encourage people to move more. Sometimes stability is not the answer. Mobility is the answer. And so disafferentation is when we have a faulty or poor input coming into the system. And so from a nervous system standpoint, I've spent 20 years of my career working on motor output when really over the last few years, I've focused way more on sensory input. If you can change the afferentation that's going into a person's system, whether that is through vision, proprioception, vestibular stimulation, touch, whatever it may be, when you begin to pay more attention to the afferentation that's going into the system, you are going to completely change the efferent motor output that that person has. We cannot change a person's motor output without altering sensory input. And I think paying attention to the afferentation that's going into the system in order to help the disafferentation that's happening is extremely important. You know, muscle guarding is a protective response. These compensatory movement patterns are, of course, protective responses. If we begin to pay more attention to the sensory nervous system and the input that is going into the system, we can begin to change motor output. So let's look at just a couple studies. This one by Hug and Hodges et al., and looking at a bilateral plantar flexion task and what that does to the non-painful limb. So basically what they did was they looked at 35 subjects performing an isolated seated plantar flexion. And what they did was they injected saline into the soleus, which is painful. So it changed their motor outputs, or they thought it was going to change their motor outputs, and we'll kind of see what happens. So when saline was injected into the soleus, what they did was they looked at the way they were putting force through a very isolated seated plantar flexion task. And so when saline was injected into the soleus, the two limbs altered the force production in a way that it transferred force from the painful limb to the non-painful limb. And so the nervous system appears to prefer to reduce the force produced in the painful leg relative to the non-painful leg, meaning that the nervous system wants to protect painful tissue. So when someone is in pain, and we've seen these studies multiple times, this is just one example, is that when someone is in pain, if given the option, they're going to shift off of that painful stimulus and off of that painful tissue and put more force through the non-painful tissue. The nervous system is going to prioritize protecting the painful tissue. So that's interesting from a movement standpoint. Again, it means basically if given the option to compensate, your patient's going to take the option. So just like if, when you're taking a selfie, you need to sort of compensate and do all the things you need to do in order to look good in the picture, same thing, the nervous system is going to alter your motor output because of a painful stimulus. It's going to compensate if given the option. So let's look at another study by the same group. So basically what they did here was they took 15 subjects and they performed 3 tasks. They looked at a knee extension, a single leg squat, and a bilateral squat. And all 15 subjects performed things under 3 conditions: a non-painful condition, a painful condition where they injected saline into the vastus medialis, and then a washout situation, which was after about 3 minutes, the saline was gone. And about 3 minutes after that, they didn't have any pain. That was considered a washout situation. And they looked at force data and EMG. So during the knee extension and single leg squat task, there was no change in vastus medialis EMG amplitude or vastus medialis shear elastic modulus. So there was no change in muscle force when they had a single leg task or a single degree of freedom task. However, during the bilateral leg squat, they saw a decrease in amplitude in EMG at both the VM and the VL during the painful situations. So it provides evidence that when an obvious solution is available to the organism to decrease stress on painful tissues, the option is going to be taken. This is what functional variability and degrees of freedom are all about. In our DAT class, that I teach in that's entitled Movement Assessment, one of the things that we talk about is the dynamic systems theory, and how the dynamic systems theory really has to do with how the organism performs a task in any given environment. And so if you change the environment, the organism is going to have to adapt. If you change the task, the organism is going to have to adapt. If the organism is hurt, they're going to have to adapt themselves in order to perform the task in the environment. So organism, task, and environment are extremely important when it comes to functional training. And really, manipulation of those variables are extremely important when it comes to functional training. And so, our job is really to give our patients the most degrees of freedom so the nervous system can select the best way to perform an activity in a given environment. And when a system is injured, when an organism is injured, they are going to have less degrees of freedom to perform a task. But if we give them more degrees of freedom by taking a unilateral task and making it a bilateral task, they're going to be able to alter their force data, their force output, and their movement pattern in order to protect the painful tissue. That's what functional variability is all about. We want our patients to have multiple ways to complete a task. We're not necessarily looking for perfect movement patterns here. We're looking for multiple ways that an organism can complete a task. That's really what functional variability is all about. So, again, tasks with fewer degrees of freedom offer limited potential to redistribute stress. And so, individual changes show that participants use different motor strategies to achieve the same mechanical outcome. So, your patient, what this basically means is that the same compensatory strategy in order to decrease stress on the painful limb was not necessarily taken, the exact same strategy was not taken by every person. People compensated in different ways. So, how do we translate this to some clinical practice? If I'm truly concerned about tissue damage, I want to provide the organism or the patient with as many possible degrees of freedom for them to complete a task. If I'm not worried about tissue damage and I'm worried more about a fear avoidance pattern that somebody is fearful to use an extremity that I know doesn't have tissue damage to it, maybe I choose a task with less degrees of freedom, like a single leg task, to force them to use the extremity that they're fearful of using, as long as I know that the potential for tissue damage is not present. So here's where I really start to utilize these concepts to select, am I going to do a bilateral task or a unilateral task? Do I want to give the body options to get off painful damaged tissue, or do I want to force the body to use the limb that they are fearful of using? This is how we can begin to justify our progressions and regressions for any given patient. And those progressions and regressions are going to look very different for every single patient we deal with. In this next section, we are going to talk about what a pain generator is and how we can influence the parasympathetic nervous system in order to help decrease somebody's pain.